to reschedule people. I just wanted to let you know that if you want to learn more about upcoming events or access videos to the past keynote speaker that we had last month, if you weren't able to attend, I've just put a link to the website in the chat, and you can go there to get links to all of the videos from all of the webinars we've done. We always put them up there shortly after we've had our recording finished and edited. And I also want to say that if you have any questions during the speaker's talk, you can put it in the Q&A during her talk, or you can put it in afterward, and we'll get to all of the questions after the talk. And so we have plenty of time for people to engage in a really good discussion. But so we've started the recording, and I think we should probably go ahead and get started. Bob?
Thanks, Jennifer. I'm Bob Hummer, another one of the principal investigators of the Network on Life Course Health Dynamics and Disparities. So welcome, everybody. We're really thrilled to have you all today. And it's my job to introduce today's speaker, who's a fellow colleague of the University of North Carolina, Chapel Hill. I'm absolutely delighted to introduce Rebecca Kreitzer today. Originally from St. Paul, Minnesota, Rebecca went to McAllister College in Minnesota, which is one of the just really, truly great liberal arts colleges in the upper Midwest. In 2007, she received her BA in political science and Chinese from McAllister. And then after a few years in the workforce, ended up going to the University of Iowa, where she obtained her PhD in 2015 in political science. Since then, she's been at the University of North Carolina, Chapel Hill since 2015, where she's been an assistant professor of public policy and of political science at UNC. Rebecca studies gender, political representation, political inequality, public policy and health, and focuses a lot on US states, which is why we're so interested in hearing from her today as part of the network's emphasis this year. Her research, among other things, studies the effect that state politics has on women's health inequalities, which is, again, central to the interests of the network. With one of her current projects, she's leading a team that's using GIS and mapping contraceptive deserts, or areas of inequitable access to affordable family planning. Her work is interdisciplinary in nature. It crosses over between political science, sociology, geography, and public policy. Again, a feature that's really important to our network. So we're really thrilled to have her for all those reasons. Beyond that, though, Rebecca says on her website she enjoys baking, sailing, forestry, travel, crafting, and maintaining family cookbooks. I'd love to hear more about this and look forward to connecting with you further as a colleague here at UNC. So thank you, Rebecca, for agreeing to do this. We've been looking forward to your talk. It's supposed to happen in April, but now it's October. But we're thrilled to have you. The network is very much looking forward to your talk today, and I'm going to turn it over to you now. So thank you.
Excellent. I'm going to start by sharing my screen here. Thank you so much for inviting me to give this presentation. This is a topic that I'm really excited to talk about because it's interdisciplinary and because it relates to a few of the things that I think are really important. And one of them being the importance of talking about state politics and the effect that that has on our daily lives, including health. Before I got into my presentation, I thought I'd give a little Zoom PSA. I've noticed that not everybody knows about this feature. So if you are interested in seeing the video of me alongside my slides, here's how you do it. You can click on the side-by-side mode thing on the upper corner. And actually, it'll default to that in the future. So just a PSA if you are interested in that. Okay, so in starting this out, I thought I would start with the elephant in the room, which would obviously be the coronavirus. So when I was first asked to talk about this topic to this community, talking about the importance of politics on health, I was excited about it because this is something that political science has started to talk about more, but I've noticed that a lot of other people, it just hadn't really occurred to them before. Well, here's a couple of motivating images. So here's, we see the state laws regarding mask mandates as well as restrictions of going out and about. And on the other side is the familiar image of the incidence of coronavirus cases weighted by population. And we can see, just looking at it, that there appears to be a clear relationship here. And in fact, there's already been some published research that does indicate that there's a relationship between the passage of state policy regarding coronavirus and how and the incidence of coronavirus in those states. And we also know that that the passage of mask mandates and other coronavirus shutdown measures are highly correlated with partisanship and with the competency of state government, rather than the severity of disease or the severity of risk. One thing that's interesting is that, just yesterday, the New England Journal of Medicine wrote only their 4th editorial ever on politics, and actually they made their first political endorsement ever. They endorsed Joe Biden for president, and they have a very scathing editorial that goes through the ways in which our government's response has been incompetent and inadequate, and that it's led to worse health outcomes for Americans. So I encourage you to check that out. And it's exciting to me to see the New England Journal and other places starting to talk about politics more within public health, because it's really important. My goal for this talk today is to give an overview of the relationship between politics and health and how they shape each other. I'll start by saying that I am not an expert in aging, and instead my research in public health has a lot more to do with health inequality in terms of access, and in particular with women's health. And so I'll give a few examples of my research throughout today, and necessarily the examples that I'll give will be swayed by my own research. And so I hope that this talk is motivating for you and helping you think about the ways that politics shapes health in regards to your own research, even if it's not exactly the same stuff that I'm talking about here. So you'll also notice that my talk today is an inch deep and a mile wide, which is by intention, so that I can expose you to a lot of mechanisms of relationships between politics and health. And I'm happy to get into more detail and talk more about the things that I'm kind of raising as questions at the end of the presentation. So here's just a couple of the ways that we know politics shape health. So we know, for example, that both the federal, state, and local governments have discretion to write their own laws and regulations and oversight. They shape the types of medical procedures that are available. They shape our own physical access to health clinics and hospitals. We are exposed to different environmental and workplace toxins depending on what states we live in and what the protective regulations are. And we also know that things like insurance and Medicaid vary substantially state by state. One aspect that people are a little bit less likely to think about is the way that politics shape our human behavior, which also down the road, of course, also shapes our health. So we know that, that politics shapes public opinion, and that this can affect stigma, the risky behaviors that we take, as well as our belief in science and medicine, which is something that we've seen very recently. So the rest of my presentation, I'm going to give some examples of these, and I'll end with some recommendations or some thoughts about embarking in this research agenda. So I'll start off by saying state policy affects us a lot. I'm a scholar of state politics, and one of the reasons why I like studying it has to do with the fact that we interact more with state policy than we do with federal policy. Even when we're talking about a federal policy like, say, Medicaid, the implementation of it varies so substantially across the states that we really ought to think of it as a state policy with federal guidance. And we should really take into careful account those meaningful differences between the states. I also like studying state politics in part because it just increases my N. Instead of just looking at the relationship between like politics and health at the national level, I can see how the institutional differences in the level of regulation of health shapes things down the road. So it also is a useful approach methodologically because it opens up different tools that we can use when we expand our N from looking just at one country to looking at state level variation in policy. So how does politics shape health? Well, one of the ways is it shapes the types of laws that we have. So one example is that Republican governors were less likely to expand the ACA. This study by Barlow and Rainey was published in State Politics and Policy a couple of years ago and has some pretty interesting methodological approach to get around the fact that all Democrats expanded access to ACA, but only some Republicans did. Well, in this article, they look at the need for expansion. So they look at the coverage gap, among other things, and they actually find that the need for expanding Medicaid is not related to the actual expansion of it. So in other words, politics is more important to Medicaid expansion than whether or not the people in those states need that health insurance. Another example from my own research is the way in which partisanship shapes the policies that we have. So in this paper, what I do is I look at things like the partisanship of people in state office, as well as the number of women who were in state legislatures. Women play a particularly significant role in stopping restrictive abortion policy. Well, what we see is that politics really dramatically shapes our access to abortion, both in terms of whether or not it's legal, but also how many clinics there are, how easy it is to navigate the administrative burdens, et cetera. Another part of my research looks at contraception. And I think this is an important way of looking at state politics, because what we're doing here is we're mapping how long it takes you to drive to a Title X clinic. So Title X clinics, in case you don't know, Title X is the only federal program devoted to family planning. And it started out being really non-controversial in the 1970s. It was signed into law by President Nixon. But it's implemented very differently in the states. And so some states offer clinics across the state. Other ones really focus their clinics in area with large populations. And so in this project, what we're doing is taking into account the state politics, as well as population trends. Where do people live? How long does it take to drive in different places? And what we find is that the prevalence of contraception deserts really varies across the US states. Some states, there are many more people who are in limited access areas. So it would take a long time for them to drive there, or there's just so many people who live there that they don't have access in terms of like the patient to provider ratios. Another way that my team looks at this is we're interested in the politicization of Planned Parenthood. So as you may know from the news, the Republicans have been trying to defund Planned Parenthood or take away Planned Parenthood's involvement in Title X. And actually, very recently, under the Trump administration, Title X has started to give some of their money to crisis pregnancy centers, which are anti-abortion clinics, instead of places that actually provide contraception. So what my team does here is that we have shown what contraception deserts are like currently, and then simulated what contraception deserts would look like when we get rid of Planned Parenthood. Well, what we find is that getting rid of Planned Parenthood dramatically increases the size of contraception deserts. And in particular, low-income women of color are the most likely to live in places where access goes down when you get rid of Planned Parenthood. So this is a good way of incorporating a lot of different disciplinary insights from different fields into studying access in a nuanced way that incorporates politics. We also know that politics shape oversight and regulations. So by regulations, I mean the policies that are enacted by the bureaucracy in the states, like the State Board of Health, rather than through the legislature. One example of this type of research by Professor Fred Bemke, who's a former RWJ scholar, he shows that campaign contributions to both legislatures and governors shape the number of inspections at nursing homes, as well as the outcomes of them. So if you are a nursing home and you want to pass your inspections, if you give money to members of the legislature, especially who are on critical committees, as well as to the governor, it's more likely that you'll get by scot-free. Obviously, that's not good. It means that nursing homes in areas where there's a lot of campaign contributions, there may be poorer practices, and obviously that can have an effect on the people who are living there. We also know that there's just not been enough oversight into the maternal mortality crisis in the US. Maternal mortality is shockingly, unconscionably high. And this is especially the case in some states relative to others. There recently has been a committee that formed in Congress to address this issue of the Black maternal, or of the maternal mortality crisis, and it's really led by women of color. And the reason why is because the maternal mortality crisis is just staggeringly bad, especially if you are a Black woman. What this shows here is that the state policies in terms of regulations, of oversight of hospitals, varies a lot between the states, as well as standard operating procedures. So some states have more recommendations and regulations for what should happen post-birth in terms of like monitoring the mother's heartbeat, as well as the babies and things like that. Well, that varies state by state, and it has an impact. And it particularly has an impact on some people with the interaction of racism in medicine. We also know that politics shapes insurance and Medicaid coverage in ways that are a little bit hard to see if you're just looking at the numbers. So one of my favorite books about the interaction of state politics and health is this book by Jamila Michener, Fragmented Democracy. I recommend this book to my graduate students, and I actually assign parts of it in both my undergraduate and graduate classes. One of the reasons why I really like it is because she combines both quantitative analysis as well as qualitative interviews. And it's in the qualitative interviews that you really begin to understand the extent to which Medicaid varies across the states and the way that that could affect people who are on Medicaid. In order to elucidate some of the key findings, I'm just going to show you a couple of quick quotes from the book. In this quote, she is talking to a person who had had a premature child born at 31 weeks with the baby weighing less than 2 pounds and weighing 2 pounds and 10 ounces. In this quote, what she says is that by the grace of God, her child was qualified because he weighed 2 pounds and 10 ounces when the cutoff for Medicaid was 2 pounds. So he automatically qualified, which allowed them to get millions of dollars in healthcare costs. But if he had weighed only a tiny bit less, or had the gestational age had been a difference of 1 week or so, would not have qualified for any of this health support. Another example, and this is a very common one, both glasses and hearing aids. There's just very funny coverage for glasses and hearing aids and Medicaid. So in this quote, someone is talking about how Medicaid told me I can get a free eye examination, but not glasses. And so in several states, Medicaid will cover both eye and hearing checkups where you can get a diagnosis, but then it doesn't actually cover the glasses or the hearing aids. So you can imagine down the road the effect that that would have. Another good example from Jamila's book interviews this man named John, who's a white man from Michigan diagnosed with life-threatening chronic illness early in childhood. He talks about how he feels married to the state of Michigan and unable to move to other states because of the ways that Medicaid coverage varies from state to state. So he talks here about how he had dashed hopes of moving to Arizona because he looked into the health coverage in Arizona through their Medicaid program, and he found that it didn't cover critical things that he needed, like in-home health care. As a result, even though he wanted to move to Arizona for whatever reason, maybe family reasons, we don't know exactly, we know that he's stuck in Michigan because that's the only place where you can continue to get the health care that he needs. Another example, this isn't based off of a research study, but based off of 5 minutes of Googling last night. On the one side, we see a map showing the majority of states that have the highest rate of adult diabetes coverage, or of adult diabetes. And on the other side, we see state mandates for diabetes coverage. Well, what's important here is that we can see that the incidence of diabetes is more common in the Southeast, where I am, but we also see that there are a number of states that don't require health insurance for diabetes. It seems very reasonable then that if you're looking at mortality rates for diabetes, it would be different for people who are living in Louisiana, where state law mandates coverage of diabetes, compared to a state like Alabama or Mississippi, where it's not necessarily covered. Another key way that politics shapes health is it actually shapes the way we think about different groups in society. Here is Julie Pacheco is another former RWJ scholar who studies health policy and politics. In this study, she's looking at the effect of smoking bans. So I show a figure here showing what kind of a state level policy is regarding smoke-free air laws, so the ability to smoke within buildings. And on the other side is a little excerpt, or the title of her paper. What she finds in this paper is that the longer no smoking policies have been in place, the more likely people are to support future policies. She shows that week by week. So if you've had a no smoking policy for a year, the people in that state are much more likely to support more regulation of smoking. She also finds that people become more concerned about secondhand smoke when they are living in a place where they have those policies. So it changes the way people think about policies that are intended to increase public health. And it also changes the way people view smokers. So the longer a state has a no smoking policy in place, the more antipathy people view smokers with, which isn't necessarily a good idea. We don't necessarily want people to view smokers with more antipathy, but this shows the public education effect that policies can have on the public. It can also get us thinking about things like a number of states have started to increase the minimum age for the purchase of tobacco products. So given what we know about the way that having policies in place makes us more supportive of having further policies in that direction, we might start to think that these states that have passed laws to increase the minimum age for tobacco, maybe there would be a lower rate of smoking. People would likely start smoking at a later age. And of course, down the road, that will have important implications for the incidence of disease. From some of my own research, I also know that legalizing same-sex marriage results in more people thinking that it should be legal. This is a pretty common finding that's emerging, and this has implications for the acceptance of LGBTQ people in society. Well, this isn't about health exactly, but it has implications for health. We know, for example, that policy shapes both physical and psychological health. Across a number of studies, Mark Hatzenbuehler and co-authors, I believe he was also an RWJ scholar, shows the effect that LGBTQ policy has on both psychiatric health as well as physiological health. So these two studies that I show here are looking at the effect of LGBTQ positive policies about things like non-discrimination and anti-bullying, as well as the legalization of same-sex marriage. In both of these studies, they find that after same-sex marriage has become legalized, or in places that have school policies to cut down on bullying of LGBTQ kids, it decreases psychiatric mental health issues pretty substantially, and it also has a significant effect on suicide attempts. This is really important because suicide attempts among LGBTQ youth are really high, especially for trans youth. And so what this is showing us is that having these policies in place is actually having an effect on the likelihood of suicide attempts, which is pretty important. They also find things like it shapes physiological health. So in this other study, again, kind of a similar research team, they showed that in the state of Massachusetts, before and after they legalized same-sex marriage, that the cost of medical care visits and the frequency of medical care visits, not just mental health care visits, decreased after the legalization of same-sex marriage. And this is controlling for whether or not those people were in a relationship. So it affected single people as well as partnered or married people. And it is also controlling for things like HIV status. So on top of HIV status, on top of relationship status, just legalizing same-sex marriage reduces medical care costs for LGBTQ people. We also know that politics shape workplace and environmental exposure. So for example, when you have more rigorous environmental policy protections, it results in less pollution. So that's good, the policy's working. And it also has an effect on public health. It can have an effect on things like allergies and other pulmonary disease as well. We also know that politics shapes poverty and wealth. And of course, poverty and wealth are highly correlated with the incidence of disease. We know that socioeconomic status is highly predictive of our health. So just a couple of quick examples. We know that, for example, TANF benefits vary substantially across the US. So in some states, TANF is much more generous. That has implications for healthy eating in families, as well as their interactions with like school, their ability to learn and things like that. But it's not just on the low end. We also see that even things like our own retirement plans, the state funding of retirement plans varies significantly too. So in states where the pension plans are better funded, more generous, of course it makes sense that people's health might be better as well, especially as they're aging. We also know that health can have a relationship on politics. This is a causal direction that I think occurs to fewer people, but has pretty substantial implications for our ability to pass healthcare reform and our ability to increase access to health. In a couple of studies, this is again by Julie Pacheco and some co-authors, she shows that self-rated health, so self-rated assessments of health, as well as depression, are associated with lower voting among young adults. In another study, she shows using two different data sets that I'm sure some of you are at least familiar with AdHealth. She shows that healthy people are more likely to vote, and they're also more likely to vote for Republicans. So what that means is that people who are suffering from chronic illness or are in otherwise ill health, they're less likely to vote. And their policy preferences are different than the people who vote frequently. So it's possible that if people who were in ill health voted more often, maybe we would have better healthcare policy because they would be engaged in politics. Okay, so hopefully I've convinced you across this like long series of examples that this is an important topic that we should be studying. There are, however, some frequent challenges with studying the relationship between politics and health. So just very briefly, here's some things to think about. Well, if you're not taking into account state politics right now, you might be thinking about it in terms of it's an omitted variable bias. Right now, we know that because of the fact that state politics can have, if you're not controlling for it in your analyses, it means that there may be some correlation in the errors in your data. Of course, we don't want to have correlated errors. So you can get around that by starting to control for some of the things that shape the politics or shape like the policy that shapes health. Of course, this is difficult because of issues of endogeneity. Health shapes politics, politics shapes health. So this is, there's ways that we can get around issues of endogeneity, including using lagged time periods and things like that. But it's at least something that we should be thinking carefully about when we're designing research around it. One of the issues that I personally have been wrestling with quite a bit is the reality that basically all data in the world is spatially correlated. So I showed earlier a slide that's looking at the incidence of diabetes in the US, and we could see that the incidence of that is spatially correlated with state politics itself. We see, we can also look at things like public opinion or partisanship. If I want to look at the expansion of Medicaid, and I'm trying to disentangle the effect of things like the partisanship of the government, as well as the state economic capacity, well, those things are related. There's some cutting edge research emerging that's using spatial, like spatial regression models that take into account the spatial distribution of data. We can also use things like in some of my own research where I take into account geography through the use of GIS. So this is an issue because a lot of the key variables that shape politics are spatially distributed, which makes disentangling the effect of politics itself a little tricky. And of course, the other thing that is difficult with this is data availability. As a scholar of state politics, I have been hoarding data for my entire career, as have other state politics people, because the data availability is a little bit less. In the federal government, at least, we're more likely to have an easier way of collecting data, whether it be from the census or other sources. And it's definitely trickier if you're looking at state politics. That being said, there's been a real push towards replication in the field of political science, and in particular within the field of state politics. Most of the work that's published in state politics today is published with full data sets available for replication. And there's also been a number of significant initiatives to collect state politics data together in one easy place. A big data set of that, the correlations of state policy, was available previously as an ICPSR download, but now there's actually a whole R package that facilitates it. So don't get too bogged down with the idea, like, where am I going to collect all this politics data that might be relevant for you? Some common variables that I think health policy scholars would be well suited to consider include things like looking at political leadership and partisanship. The NEJM editorial is keying in particular about incompetency in our political leadership. And in fact, the preliminary research that we have on coronavirus in the states is also showing the key role of political leaders in state government, and in particular, the role of partisanship among our leaders. We also know that public opinion and mass partisanship can also play a key role. So again, here, think about things like public opinion on the issue of smoking is going to change the frequency of, or like what the smoking rate in that state would be. And also, you could think of other examples too, but the way the mass public interacts with a policy issue can shape the targets of that policy or the people who are involved with it. So if there's a lot of frustration about Obamacare in a state, and so they don't want to expand Medicaid, that could be relevant for your research to investigate that. Another key variable for state politics is looking at state economic capacity. So one of the main reasons why state governments will enact more policy or choose not to enact policy in a certain area has to do with their economic capacity. How much are they raising in taxes? What's the state median income, and things like that. And finally, the professionalization of legislatures and executives is really important. Professionalization is a concept distinct to political science that means different than maybe what you're expecting. So professionalization doesn't have to do with like how they're presenting themselves to the world, but rather it has to do with what's their salary, how much money are they making, or do they have staff that help them, how many days a year do they meet? So some states, the government only meets every other year. So the state of Texas, for example, the legislature only meets every other year. And that has big implications for health too. Across the literature that I've read, the states that have less professionalized executives and legislatures do a lot less for public health. Okay, so there's a couple of journals that you should check out, especially if you're increasingly interested in these topics. Three of the journals within the realm of public policy and political science that I think are relevant would be JHIPL, the Journal of Health Politics, Policy and Law, State Politics and Policy, which has a full replication requirement prior to publication, so easy place to get data, as well as the Journal of Federalism. But I've noticed in recent years that there have been some really great work published in places like the AJPH, NEJM, Pediatrics, that are also looking at the effect of state politics. And actually not just state politics, I believe NEJM had an article about the Women's March a couple of years ago. So they're starting to incorporate more findings from social science about what shapes health. Okay, so that's like the inch deep and mile wide introduction that I wanted to provide you to the world of politics. Hopefully this has generated some ideas for you about things to think about. And I'm really looking forward to having a conversation and answering questions and helping to generate ideas moving forward. So I'll stop my screen sharing, and I'm really happy to take questions.
Okay, Rebecca.
Oh, yes,
Bob.
Sorry.
I didn't know if Bob wanted to say something or not. Maybe not. Okay, well, while we're waiting for just a couple more questions to come in through the Q&A, I had kind of like a very general question for you that might be difficult, but I think you're the most expert to answer this question, which is, how should researchers, A, think about the system of federalism and the relationship between federal policies and state actions to comply with regulatory frameworks, for instance, and B, how should researchers be thinking about how to communicate what is a very complicated and complex system of federalism in this country in a way that helps people to understand that kind of complex interplay between the federal level policies and the local level actions and activities.
Mm-hmm. Yeah, so I should start with like explaining the concept of federalism, perhaps. So federalism is the idea that you can divide the power of government by giving different amounts of power to various levels, and that they can put checks on each other so that each of the levels of government are able to restrain the influence of each other. And the idea behind federalism starts with the colonial era, when they realized that each of the states had kind of like distinctive needs and personalities and origins. And although that's no longer like the reason why we talk about federalism today, instead we think of it now as like the laboratory for democracy. So as I'm sure most of you all know, the ACA is based quite a bit off of Romney Care in Massachusetts. So today, a big part of the role of federalism is to kind of like try out different policies, see if they're working, and then states tend to learn from each other. We also, in the US, we are a conservative country. I think a lot of people who live here haven't really thought about it that way, but when you compare our country to other developed countries, we tend to be, like, just political ideology wise, we're conservative. I mean, in fact, liberals in the US are about as conservative as conservatives in the UK. Well, this shapes what we think the relationship should be between government and the mass public. And in the US conservative tradition, we really put a lot of deference towards local politics and local government. We talk a lot about how the states are distinctive and we have distinctive policy needs and cultures and preferences. And so as a result, even our biggest federal policies are to a very significant degree shaped by state politics, both in terms of the content of them, things like how Medicaid, or what things Medicaid covers and what things it doesn't, as well as the implementation of it, like how easy is it to get. We saw that recently with the CARES Act and with unemployment. We see that in some states like Florida, they intentionally made it super hard to get unemployment. And in fact, most people were denied for it as compared to other states. So federalism in the US, I'm not sure if that fully got at your question, but federalism in the US, there's good sides to it. We can trial out new policy, but in my own experience, it tends to result more in health inequality because it denies policy or health access to some people.
Yeah, that was really helpful. And I just want to make a really quick plug before we get to the Q&A, that one of the society journals for the Gerontological Society of America is Public Policy and Aging Reports. And we actually will have an issue coming out written by members of the network, like Andy Fenelon and Shannon Mana and Daniel Rhubarb and Todd Hamilton. And Sarah Burgard took the lead on writing kind of a broader framing piece. But we were, I think, many of us, and certainly in the framing piece, we were kind of struggling with a lot of the topics that you were talking about. And so like I wrote a piece on air pollution and was trying to explain that it's federal policy in terms of the regulatory frameworks, but it's all kind of executed at the local level. And of course, the effects are felt at the local level. And I think that some of us in this group maybe feel a little out of our depths because we're not sort of enmeshed in that kind of policy arena. So anyway, I thought your talk was really excellent for kind of blending together a lot of really interesting points.
Yeah, and I would point you to Jamila Mishner's book, which is excellent. I mean, I went and nominated it for book awards. That's how much I'm a fan of it. And it does a particularly good job of explaining the implications of federalism for health. So it was a great place to start if you want to get up on the lit.
All right, so I think I'm just going to read some of the questions in the Q&A now that we've had a few more roll in. So one of the attendees wanted to know how political competency is measured.
Yes, that's a good question. Political competency. So that is not a very distinct, that's not a clear measure in terms of how we measure it. So some people look to like what their qualifications are and how qualified they are for office. And so we know, for example, that women who run for office are like 10 times more qualified than men who run for office. And that just has to do with like gender stereotypes and things like that. Other ways that people look at competency looks at like how effective they actually are at passing policy. So there are some measures of competency that look at like legislative productivity. The NEJM editorial in their like operationalization of competency is they're just looking at like, are they passing things that are in line with science? And so they don't have like a very clear definition of it. So unlike other terms, there's not a definition for competency, and that would vary by researcher.
Okay, and kind of ripping off what you just noted, one question is, what is the trade-off between politicians' need for short-term policy victories and the long-term investment needed for improving population health? Or is there a trade-off?
No trade-off. In fact, political scientists often repeat this phrase, policymakers are single-minded seekers of re-election. And they really are. Although policymakers are also interested in shaping public policy, they can't do that if they're no longer in office. And so really the thing that's most key to them is getting reelected. So that means short-term gains.
Okay, and following, I feel like our attendees are super on the same wavelength, which is great. Following on that, another question is that you gave some examples of how people become more supportive of a policy after it's passed. Mm-hmm. And there are other examples like Medicare and Medicaid that were very controversial when they first passed, but they're like very widely accepted and some of our most popular policies. Mm-hmm. Does this suggest that policies should be pushed through despite public opposition, since eventually the public will, quote, come around? I feel like this question is so relevant at this moment.
Yeah, well, so, okay, that's a complicated question. I think the interpretation of the research is really accurate. So we know that once policies are in place, it makes people more favorable towards them. The ACA is a really good example of pre-existing conditions, insurance for young people. The longer policies are in place, the more we love them. Does that mean that people should push for policy that's like politically unpopular? That's a normative argument. So perhaps if I was putting on like my own normative hat, I would say, yes, politicians should advocate for policy that's not popular if it's good for public health. But we are a democracy, and other people have a different idea about what the role of government is and think that government policy should be responsive to the people. So I think that comes down on what you think. If you think government should be looking out for us, or if you think that government is a mechanism for representing what we want. And if what we want is bad public health, some people would say that's democracy. Yeah, so I don't know if that answered it either. I mean, I would say, yes, we should push policy to be better for public health, but that's not what everybody thinks.
And so kind of returning to the a topic from just a few minutes ago, how do you incorporate considerations of further devolution of administrative responsibility for public health policies like Medicaid to local governments into your research? And so the example given is in some states, there might be greater within state differences in public health than differences between states.
Mm-hmm. Yeah, this is a growing trend that we're seeing not just within public health policy, but in other things too, like utilities. There's a push for decentralization, especially among conservatives, with the idea that when you decentralize it, then it can be more responsive to what local needs are. The research on decentralization generally shows that it's worse outcomes, that when you further decentralize things like water utilities, or when you further decentralize things like health implementation, it's better in some places, but a lot worse in other places. And by a lot worse, I mean, it means that access can be worse. It also means that the implementation, like the competency of the people who are administering it, can also be worse. So the trend towards decentralization is one that I think we should be concerned about. The evidence doesn't suggest that it produces good outcomes. And in fact, it tends to show that it increases inequality.
Oh, Bob, I didn't know if you wanted to add anything.
I do. Thank you, Rebecca, so much for your talk. And one of the things that I think about a lot in this area and that is migration, and the idea of states as actors, that people are move around and states change based on who's there, who's not. And I always think about experiences of Mississippi, Louisiana, Alabama. We like to pick on states like that, but in many ways, a lot of people leave there, if they see greater opportunities elsewhere. And so kind of thinking methodologically, how do you best think through issues of migration and how they're influencing what states do and how they act, and in comparison to what what might they have done had people not out migrated so much or in migrated and so forth. This relationship between migration and states as actors.
Yeah, that's a really good question. I think that's an area where I haven't seen a lot of research, so I think more research in that area would be good. Though I'll say I'm not sure how much migration is really caused by some of these things, and especially we see a lot of evidence that people can't migrate as easily. People often say like, well, if you don't like the laws there, you could just move to another state. It's actually not that easy to move to another state for most people because of financial, personal, family, whatever. So I actually think that the migration across states is probably less common than a lot of people assume it to be. And what's more, the people who are migrating are the people who are in better health, have more political power and influence, and the people who are kind of stuck where they are the powerless and the people who are in iller health. How does that change the incentives for policymakers? Well, there is evidence that policymakers learn from each other. So there's a whole literature on what's called policy diffusion, which is the spread of policy from one state to another. And there's evidence, for example, that states are more likely to adopt policies that their neighbors have passed with this kind of idea of like, oh, people are going to cross state lines. So for example, sometimes with abortion policies, if one state passes a strict regulation, the neighboring state will do it too, because they don't want people crossing the state line and then their own abortion rate's going to go up. So we do see some evidence that people cross administrative boundaries like states for health, but I'm not sure how common that like permanent migration is. I do think that we should keep in mind like who's migrating, and of course it's the people who are more politically powerful. And I don't think politicians have all that much incentive to pay attention to who's leaving. As long as it's not really affecting the state economic health overall, I don't think they really care if they lose some people because they're moving to a neighboring state.
We've now entered the more of a comment than a question period of this, which I think is appropriate. Yeah. So there was a comment that says, I suppose one could argue for better education of the populace so that popular opinion becomes more in line with the best evidence on how to improve population health, which kind of refers back to the prior question about policies being popular or unpopular. So to kind of, it does seem like, so this discussion is happening right now amongst, people in Biden's camp that if he wins election, should he just immediately basically sign 4 pieces of new legislation every Tuesday, I think is what I saw someone suggest. Which personally, I think anyone signing a lot of legislation would be great because it doesn't seem like our legislators have been legislating lately. But the idea was that, and maybe with the ACA as well, one of the criticisms was that where they failed with the rollout of the ACA was actually the lack of educating the population on it. And I know I remember after the 2016 election, Paul Ryan was really adamant about the idea that the passage of the ACA had somehow damaged the integrity of Medicare, which I was shocked by as an aging researcher. So I looked into it to try to figure out what was going on, only to find out that not only had the ACA not taken funds from Medicare, but it had actually created some powers within the legislation, some authorities that actually ensured the integrity of Medicare for like decades to come. So it does seem, I guess maybe, although this was a comment, I'm curious what you think about the idea of you had that slide where you talked about there's policy and there's human behavior. Some linkage in there must be something about kind of communication and education, and that falls on both policymakers and researchers, I would imagine.
We are living in crazy times, as everybody knows. And one of the things that is a hallmark of this era is polarization and partisanship to a degree that we just can't relate to. And a big consequence of that polarization and partisanship has to do with misinformation, where people get sources. So a big problem today is that as much as we can try to educate people about what to do about coronavirus, about what the ACA entails, all of these things, people have incentives to Yeah, so there's two processes here. So one is that we tend to seek out information that coincides with our previously held beliefs. We do not like to be told that we're wrong. And so when we're confronted with education that we don't like, we just won't learn from it. We'll just choose not to learn from it. And we also are reading just very particular news sources today. So people who believe in science and medicine are not really reading Fox News. And those are frankly the people that we probably need to be doing more education about health and science. So this is a big problem that we're wrestling with that I think extends far beyond the issue of health. And how do we overcome it? I honestly think before we can get to re-education of people, we have to ramp down the polarization and partisanship. There's been some good research about polarization and partisanship. My favorite book right now on that is Lily Mason's book called Uncivil Debate. And what she argues in that book is that today it used to be that, we have in-group and out-group attachments and that we prefer for our in-group or our political party to win. Well, what she actually shows is that today we care less about our own team winning, but we care more about the other team losing. And that's like the level of rancor that we have today in society. And so that really shapes our attempts at educating people about policy.
Thanks. We have some more questions, like really good questions. Someone asks if you think the trend toward local decentralization is more relevant in blue states because of state preemption laws than it is in red states.
I'm working on a paper on preemption right now, actually, and it's pretty interesting. And there's actually preemption attempts and decentralization in both red and blue states. They're just doing kind of like different things with it. So the red states that are preempting policy, they're upset because there's liberal cities that are trying to like infringe on what they would prefer. And then in blue states, we're seeing a preemption as well, just on different issues. So it's not clear to me that it's a red-blue issue, though it's more, it tends to be the case that Republicans and conservatives prefer preemption. When Democrats prefer preemption, it's because they don't like how conservative policies are. So it tends to be things like here in North Carolina, the city of Charlotte passed this infamous HB2, or it resulted in HB2 because they tried to like improve minimum wage and things like that. So the preemption kind of politics divide is like very partisan. And honestly, everybody's preempting depending on which state they're in. Blue cities and red states is a big dynamic right now.
Okay, and we have a question thinking about spatial correlation and endogeneity. In terms of how social phenomena are tied to place, is it that state reputations shape policymakers and policies? Can policies and policymakers change a state reputation, and how durable are these reputations?
Well, that's a good question. I think, of course, they can change reputations, but reputations, like stereotypes, are sticky, and they tend to be harder to overcome. And so I would be more inclined to think that it would go the other way, that politicians are kind of born of the state reputations and of kind of like the political culture in the states, rather than their ability to shift those the other direction. Yeah.
And someone has a question that, I mean, I don't know if you even know the answer, but certainly you would know better than the rest of us, about what does political science know about how politicians decide on bringing policy and voting on policy given public opinion versus the politicians' funding sources?
Oh, sorry, can you say that one more time?
Well, if there's any kind of work in political science about how politicians are deciding what legislation to bring forward and how to vote it between public opinion of their constituents and the opinion of their funders.
Yeah. Okay, gotcha. Tons of research on this. So this varies across the states, but in general, whatever party is in control of the state, like legislative, especially the lower chamber, but whoever is in charge of the state houses, they have huge discretion on which issues actually make it to a vote. So it's well known that most bills that are introduced die in committee. And it's only when the Republican Party wants do they bring it for a vote. So we've seen a little bit of those dynamics in Congress. It's the same thing in the states. Do they care about public opinion? My answer is basically always no. The only public opinion they care about are their co-partisans. So Republicans don't really care if Democrats really want people to vote on something. They're going to care if Republicans want them to vote on it, because that's going to shape their own re-election. So do they care if the other party is really ramped up on an issue? Like, no, they don't. So what's the biggest like explanation of what issues make it to a vote in Congress or state legislatures? It's completely the partisanship of whoever has the most votes.
Okay, and Andy Fenelon wants to know if U.S. policy undervalues children's health because they can't vote.
Yes. Yes, and we see that not just with children, but with other vulnerable populations too. If you think about it, if we're thinking about like health and who gets attention, old people vote a lot. In fact, they have the highest rate of voting in the US. And so it's not really surprising that there's more policy attention put towards like elderly people because of the political mobilization of things like the AARP and other like organizations of elderly people. There's a lot more attention on public health for elderly people than there are for people who don't vote. And so really our policies are tied to who's participating because, as political scientists would say, policymakers just care about their reelection.
Can I add a little, make a plug for an advertisement on this? Sam Preston was president of the Population Association of America and gave an address on this issue in 1984 that I think was really profound, and he's going to be giving an update on that address on December 8th as part of a PAA series on presidential addresses. Barbara Antosa, who's on this call today, is going to be a part of that panel, along with Arlen Thornton and I forget the fourth person, but Sam is going to weigh back in on this particular issue about the underinvestment in children's health and well-being. So I think that would be useful. December 8th at 1 p.m. Eastern time.
Let me add like another example too. Like there's a lot of political mobilization on breast cancer. There's like way disproportionate research on breast cancer compared to other things, as well as like funding and policy initiatives. So I think this is a really important thing for people to think about. Who is active on mobilizing people on issues of health? And there's a strong relationship between research funds for those things as well as policies. It's great to be getting an update on the underinvestment in children's health, because I think we're still seeing that completely.
Okay, I think we've exhausted all of the questions in the chat. I don't know, Sarah, if you wanted to add anything or if you had any questions.
No, did you get all the ones in the chat, like the other chat, the Q&A and the chat? Great, fantastic. No, I was just, I'm sorry I had to come late. I was another conference, and I am excited so much, Rebecca, and I think you also it's helpful to hear the book recommendations for other folks in your field. So those are just dynamite, and I'm really, really excited. I had a student who spent a lot of time in her dissertation working on states as laboratories for understanding tobacco policy, and that was my first foray into learning a little bit more about the kinds of things you were talking about today, and it's a really, really hard thing to do well. So I commend you on a really, really clear talk, and I think it's been inspiring for a lot of us to invest a little more in this direction.
Thank you. I'm glad. I wasn't sure the approach to take with this talk, so I'm glad that this was helpful for you all. And I'm genuinely excited to build more interactions between public health scholars, sociologists, et cetera, and political science, because I think these are really important issues. So I love being an interdisciplinary scholar, and I'm really happy to help if anybody here has additional questions or wants advice on where to seek information. Please feel free to reach out to me.
Great. Well, thank you so much for this keynote. It was wonderful. It was well worth the wait. I just want to remind people that the next webinar event is occurring on November 6th. It occurs at the same time, always on a Friday. This one is with Scott Landis. But also that in December, we're shifting from the talks to a tips session on how to prepare NIH proposals. I believe Amelia Carricker has agreed, she can't get out of it now, no backing out, to chat with you all. And again, you can check the website for any of those event details. And also, if any of you are not on our listserv, just make sure that you send an email, and I'll put the email link in the chat, and we can add you to the listserv so that you can get all of the updates and kind of latest and greatest in terms of what's going on with the network. So thank you to everyone, and thank you again to Rebecca. I hope you all stay safe, healthy, and happy, and we'll see you next time.
And I just want to thank everybody again, and I want to remind you that I will be sending out an email reminder for Scott Landis's talk in November 6th.
Great.
Okay?
Thank you, Rebecca. Thanks, Jennifer. Thanks, everybody, for attending. Take care.
Thank you.